Thank you for joining us on this exciting webinar on updates in progressive familial intrahepatic cholestasis prevented by myself and Nadia Ovchinsky.
This is our classic treatment algorithm. Whenever we made a diagnosis of PFIC in a patient, what do? Our first approach is, of course, nutritional and supportive care, followed by trying to control the main symptom that affects quality of life of our patient, which is pruritus. And we used to have a number of medications that we could use for pruritus in these patients, even though they're not really approved for this indication. In patients where medical treatment did not work, we would have an approach of biliary diversion and then finally of liver transplantation. So let's go through some of our treatment options. Well, supportive care includes strong nutrition support, addressing nutritional deficiencies, including fat-soluble vitamin deficiencies, trying to minimize cholestasis by using some medications as much as we can, and we're not able to do such a good job with this, and improving quality of life and sleep, especially focusing on pruritus, and monitoring of comorbid conditions in our patients. There are currently no guidelines for treating pruritus, and there are some non-pharmacological treatments that we use, especially in smaller infants, cutting the nails short, keeping hands covered so they don't have access for scratching themselves, using emollients, warm baths, and keeping the skin as moist as possible. These are some of the conventional treatments of cholestatic pruritus that have been used in cholestatic disorders, including ursodeoxycholic acid, which is a choleratic stimulating bile flow, hydroxyzine, that's an antihistamine, as well as other classes of antihistamines. Rifampin, even though we do not know the exact mechanism, it likely acts as a PXR agonist. Naltrexone, which is an opioid receptor antagonist, cholestyramine, a bile acid binding resin, which leads to its own issues of malabsorption and other complications, and finally some SSRIs, especially sertraline. Again, none of these are approved for treatment of pruritus in cholestatic disorders. So once we've exhausted some available medical therapies, then the next step to offer to these patients would be surgical treatment. There are a few versions of biliary diversion. They're all either external or internal, but they're all meant to reduce intrahepatic circulation and decrease retention of certain substances, including bile acids and bile salts, that we think may contribute to pruritus, as well as potentially to liver disease progression over time. And we have evidence in PFIC that most patients who underwent surgical biliary diversion, the most common indication is actually pruritus. There are some clinicians that are even doing this to prevent potential progression of liver disease. So this was a widely used operation in this patient population. We also know that reductions in serum bile acids after surgical interventions have been associated with prolonged native liver survival in patients with cholestatic liver disease, and especially in subtypes of PFIC. So what about the next step? Well, there are many patients who continue to progress and require liver transplantation. Most common indications for liver transplantation is end-stage liver disease with complications of portal hypertension and other things that are associated in patients who have really advanced liver fibrosis. But in a subgroup of patients, this is still done for refractory cholestatic pruritus. And then there are other complications such as hepatocellular carcinoma that will require liver transplantation. This is a recent systematic review and a meta-analysis that was just published a couple of years ago, looking at outcomes of liver transplant in this complex patient population. And in fact, what we've learned is that in patients with FIC1 deficiency or PFIC1, it's very common to develop diarrhea. And in those who develop diarrhea, there's also steatosis in the graft after liver transplantation. What this meta-analysis had shown is that biliary diversion that's done at the time of transplant or post-transplantation can actually protect graft from injury with an efficacy of 100% in terms of ameliorating steatosis and 95% in improving diarrhea. Patients with PFIC2 can also develop a very different type of injury. So this is antibody-induced BSEP deficiency. So it's almost like a recurrence of a similar jaundice and presentation of cholestasis. And we know that rituximab-based treatment regimen can effectively improve this complication in BSEP deficiency. PFIC3 patients did not have any specific PFIC complications following liver transplantation. So what about a new treatment algorithm? Something has changed in the last few years where there's a new class of drug called IBAT inhibitors, and we'll go into them, that have now entered our algorithm of approach to treating these patients. And it's possible to utilize these medications early on before we even use other therapies, especially biliary diversion. So what's our rationale for early introduction of IBAT inhibitors? Well, let's look at the ileal bile acid transporter inhibition and its role. So we know that the majority of bile acids that are excreted are actually reabsorbed by this very specific protein located in the ileum, and it's called an ileal bile acid transporter. And the majority is actually undergo this intrahepatic recirculation and return via portal circulation to the liver. When we're doing our biliary diversion surgery, we are trying to eliminate this intrahepatic circulation. And recently, a drug was introduced that's a very specific inhibitor of this protein. So it's an IBAT inhibitor. Doing what we've tried to achieve with surgical diversion, or reducing the bile acid load that comes back to the liver through this intrahepatic circulation. And we now have two drugs, adavixabat and maralixibat, that are both approved for use in progressive familial intrahepatic cholestasis. We're starting to get some long-term data from use of IBAT inhibitors. And if you look, for example, at this recent study, we can see that there are patients who are definitely responders to adavixabat, patients who are partial responders, and then patients who are non-responders. And we would like to look at their native liver survival according to response in reduction of serum bile acids. So if we look at the patients who are responders in terms of their serum bile acid reduction and native liver survival, it's 100%. And it's also much higher in partial serum bile acid responders than in those who are non-responders. In fact, all patients who had a pruritus response at month 6 remained transplant-free. So it's very impressive data that kind of goes along with our clinical knowledge that if we can reduce serum bile acids and control pruritus, then potentially we could increase survival of the native liver over time. We also have some longer-term data now on improvements in heights and weight Z-scores in this complex patient population. And this is data with adavixabat for 96 weeks of treatment. We have also seen similar efficacy in a recently published study, March PFIC study, that focuses on maralixibat. So we know that in both, and they had a cohorts of just BSAP patients and then all PFIC patients. So in both BSAP and all PFIC cohorts, there were improvements in pruritus severity, as well as reductions in serum bile acid concentrations that were seen very early on by week 2 and basically maintained throughout the study. There was also a greater pruritus and serum bile acid response rates in maralixibat group versus placebo group, again, in both BSAP cohort and all PFIC cohorts. So this data is very strong and consistent. So Pat, I just want to come back to you and have you introduce this potential new treatment algorithm.
Thank you, Nadia. And next slide, please. And I think when you do, yeah, thank you. Thank you for that overview. So I think we now are in the state where we say where somebody has symptomatic PFIC disease, we have very good data that IBAT inhibition treatment is effective in a majority. And what I think is becoming particularly apparent with that GROW data, it may well be that these drugs are not just effective for managing the complications of the disease, but the fact that the children are showing catch-up growth in this disease implies that these may be changing the natural history of the disease. We're also living in a time in which most of us have access to rapid genetic testing, and we can get the results of the tests very quickly, and then we can plan treatment. But that's not always the case. And I think for some people, they may have a significant delay in establishing a genetic diagnosis. And this is at a critical time in that interventions early in the course of the disease are likely to have a long-term impact. And we know that the treatments we use generically, as we have already heard, tend not to be very effective. And they certainly do not change the natural history of the disease. So what do we do with a child who we suspect has a genetic disease and we haven't been able to prove it? And I think given all that body of data, there's a lot to say to have an algorithm developed so that we could start an effective treatment on those children while we're awaiting the genetic results, and then see what happens when we get the genetic results and also what response they have made to the treatment. So we just started to think about two groups of children where we might suspect progressive familial intrahepatic cholestasis. And these are children that are presenting with what is unexplained jaundice and or pruritus. And there's two easy distinctions phenotypically to be made. There's the high gamma GT group, and I'll come back to that. But what's more likely is that we'll find a group of children who have elevated bile acids and a low gamma GT, and this is much more likely to fall into the group of progressive familial intrahepatic cholestasis. And given that, it would seem very reasonable in this suspicion to start a trial of an IBAT inhibitor. And for this here, I've suggested odevixibat at the starting dose of 40 micrograms per kilo per day, and a clinical trial of this for a 12-week period while awaiting the genetic results and the clinical response. Next slide, please. Now, the 12 weeks was suggested because that's the time course in which most children who are going to respond to an IBAT inhibitor do. So I think the time to assess that is after 12 weeks. If the pruritus is improved, then we can say, that the disease is having an effect, and the drug is having an effect on the disease, and that's a relatively easy decision to continue the IBAT inhibitor at that current dose, and then reassess when we get the final genetic results. If there is no response in pruritus or jaundice, then there are two aspects. And the first thing, it is not unreasonable to give a higher dose of an IBAT inhibitor. And in this, talking about odevixibat, I'd suggest going from 40 micrograms per kilo per day for 120 micrograms per kilo per day for further 12 weeks in a similar clinical trial. Next slide, please. And again, obviously, if with the higher dose, things have improved, then it's very then there is a logical to continue the dose. And of course, then this can be reassessed when the results of the genetic results be available. And obviously, if there's at least one genetic variant in the PFIC disease, and we've shown a response to the drugs, then it's very likely that we would call this probable PFIC. If we have two pathogenic mutations and a clinical response, then we call it definitive PFIC, which has responded to treatment. Now, there is, even today, there will be some disorders in which we don't yet have a genetic diagnosis. We might move on from a genetic panel then to a whole genome sequencing. And it's very reasonable, if the child has shown a clinical response to the drug, to continue it at that time. Now, what do we do?
May I ask you about how do you measure a response? How would you define whether a patient responds or doesn't respond to treatment?
There are two, no, I think that's a crucial thing, and I'm sorry that I didn't highlight that. That's a crucial. There are two ways to do that. The first is, has the itch got better? Have they shown a clinical response? And complementing that, have they shown a significant fall in bile acids? I think they complement each other. And considering this group of treatments where children may end up on treatment for potentially lifelong, my instinct would be to do both. Would be to document whether or not pruritus is improved and to document whether or not there's been a bile acid response. Because the implications for the child are significant. Thank you for that, and for making it clear what a response is. So I think the decisions are relatively easy for those who've responded. There will be some decisions to be made when we haven't established a specific genetic diagnosis, and that's a process that will continue in the background. Now, again, the other corollary of that is, of course, that if an IBAT inhibitor has not shown a clinical or a biochemical response, then there's no need to continue with that drug, and it would be entirely appropriate to stop that drug and then consider, depending on the clinical status of the child, returning to what our historical algorithm was, including our other successions of drugs, which, as we know, are individually of limited efficacy.
And I think it's very important, that now a response to IBAT inhibitor treatment can actually help us establish the diagnosis. As you mentioned, we used to struggle if we get one genetic variant, how do we interpret this? And I think a response to IBAT inhibitor, as you said, can really help us establish this. And it's really important for clinicians and for families that this is a probable PFIC, even though you only have one genetic variant, but there is a significant response to IBAT inhibition. And like you said, there's access maybe to rapid genetic testing, but, in order to obtain whole genome sequencing, it can take months and months for us to wait and to leave this child without therapy.
I completely agree, and I think it's defining response, as you say, those things. A clinical response with a significant improvement in pruritus, and I think this is something we know when we see it. There are scales for measuring pruritus, but to those who have significant pruritus, their family tell you whether they've improved or not. We don't need a scale for that. It's improved or it's responded completely. And I think we know how to define that response. I know it's important that for research studies that we document that in this scale. But in the real clinical world, we know that. Parents come in and say, he's better, she's better, other things. But I do think, because of the long-term implications of this, I think it's very sensible to also back that up with a biochemical response to at least once have had a baseline level of plasma bile acids and then a post-treatment response to bile acids, which provides a very objective measure of the response to these drugs. And what you've already seen is that people who respond, as far as we can tell, continue to be medium and we hope long-term responders. Now, the other group to consider is of course, is the high gamma GT situation. So, and next slide, please, where we can read this. So the other group is where we've got an increase in bile acids and a high gamma GT in the presence of pruritus and or jaundice. Now, the differential diagnosis here is different. In young infants, it's crucial that we follow our clinical protocols for how we investigate children with neonatal cholestasis so that we can exclude conditions like biliary atresia and common disorders such as alpha-1 antitrypsin deficiency. And in older children, it's important that we would exclude autoimmune diseases such as autoimmune hepatitis or sclerosing cholangitis, which have proven and very effective treatments. But if that initial screening is negative, then it seems very reasonable to consider that this is a likely PFIC, most likely PFIC3. And again, why wait a long time for a genetic analysis when we can do a clinical trial? And again, I would say we are suggesting the same kind of approach. But first, PFIC3 is one of the situations in which ursodeoxycholic acid, our very safe, long historical medicine that we use in cholestasis. Recent work has shown that a significant proportion of young presenting children with PFIC3 will respond to ursodeoxycholic acid. And again, if they respond to ursodeoxycholic acid, they are likely to become long-term responders to that. So in this group of diseases, it's very reasonable to start with a trial of ursodeoxycholic acid and seeing whether there is a clinical or biochemical response as before. And again, for those who respond to ursodeoxycholic acid, they're likely to maintain on this long-term, possibly lifelong. But again, for those who do not respond to ursodeoxycholic acid, this is the point that we would suggest the similar algorithm. Sorry, next slide. With the introduction of an IBAT inhibitor in an initial dose of 40 micrograms per kilo per day, and for a 12-week trial. And again, if this was ineffective, around 120 micrograms per kilo per day for a clinical trial of up to 24 weeks. And then reassess the situation in the light of a biochemical response, a clinical response, and the results of the genetic analysis. And we may be in the situation where we know we have a confirmed PFIC3, and if they've responded to an IBAT inhibitor, they will benefit from staying this long term. And we may have probable and possible cases, as in before, in which we have not established the diagnosis. But if there has been a clinical and biochemical response, it seems very reasonable to continue with the IBAT inhibitor treatment at this stage. And again, similarly, as in low gamma GT cholestasis, and where we considered ursodeoxycholic acid, if there is no response, then there is no point in continuing with this treatment, and it's time to restart looking for the alternatives in the algorithm, including other medical treatments and or surgical treatments. And obviously, for those who do not respond, as we've heard earlier, liver transplantation continues to be a very effective treatment for end-stage liver disease, with the caveat that Nadia has also referred. In PFIC1, there is significant risk of residual disease, but we know that this will now respond to surgical intervention, and we also know that this will respond to IBAT inhibitor treatment things. So for a disease that was previously felt to be untreatable, we now have treatment options that are effective. With PFIC2, as we've heard, there is a risk of immunological recurrence, and as a group, we tend to manage these children with slightly higher levels of immunosuppression than other children. Odevixibat and maralixibat are both approved for the treatment of PFIC and Alagille syndrome and are being evaluated in clinical trials for biliary atresia. But there are other IBAT inhibitors available, and one of the exciting things is there are new drugs in the pipeline, and we would hope that in the future there will be clinical trials of new drug treatments for those who do not respond satisfactorily to the IBAT inhibitor treatments. So overall, I think we're now in an exciting time of where the management of neonatal cholestasis has improved and continues to evolve. I think there's a very strong case that in addition to our nutritional management, that the early use of IBAT inhibitors in a clinical and biochemical trial is likely to change the natural history of the disease. These drugs are very effective against pruritus, and it's likely in the future we will use far fewer of alternative antipruritics such as rifampicin, ursodeoxycholic acid, naltrexone, etc. Many of these drugs of which we know are of limited efficacy and some toxicity. It's likely that in the era of IBAT inhibitors, the indications for doing biliary diversion are likely to decrease. It is very unlikely that somebody who has not responded to an IBAT inhibitor will respond to biliary diversion. And I think in this day and age, it's unlikely that will be explored. There may be circumstances in which there are problems with availability of IBAT inhibitors in which biliary diversion will continue to be done. But overall, the indications for biliary diversion are likely to decrease with time. Liver transplantation will continue to be the definitive treatment for end-stage liver disease, resistant cholestasis, resistant pruritus, and suspected cancer in all of the PFIC types, with the caveats of what we've mentioned about disease in PFIC1 and B-sept deficiency. In addition, particularly for PFIC1, we know that transplantation, unmodified transplantation, is not the definitive treatment, and that ongoing definitive treatment will require liver transplantation in combination with either an IBAT inhibitor or a biliary diversion. And the success of this is that a condition that some people felt was untreatable now has a number of treatment options, which is a great progress. We like to recommend the article on which this webinar was based in Journal Hepatology Reports. I would like to thank you for your interest in this area. Thank you. Sorry, I don't know. Should we say something else to end on, Nadia? Sorry, Nadia, that's what I have.
It's probably a new era in diagnosis and treatment of this significant group of cholestatic disorders that we refer to as progressive familial intrahepatic cholestasis. I'd like to thank you, Pat, and your team for putting this guidance together that will help us as clinicians approach this group of patients and hopefully introduce treatment of IBAT inhibitors early on.
Thank you, Nadia. And I think it's nice to work with you on this. And it's nice to remind us that these progresses in the management of childhood liver diseases have come from collaboration internationally, which have allowed clinical trials such as these for the IBAT inhibitors, which have transformed the management of some types of childhood liver disease. Thank you.